Greetings. I'm sorry I wasn't able to hear everything, but the chair of our department was giving the annual oration, and I thought it was a wise thing to do to show up at the Erie Crown Theater. So let's have some audience participation. Who's this? Okay, the answer to that is Copernicus. He's somebody who challenged conventional wisdom and did well. How about this person? That's Galileo. He challenged conventional wisdom, and he had to eventually retract if he wanted to survive. Now, how about this person? Somebody from England might know this one. It's Guy Fawkes. He challenged conventional wisdom, sort of, saying that we don't really want Parliament the way it is, and he paid with his head. And this is just to say that there are ways of challenging conventional wisdom. You don't want to go to too much of an extreme, or you could end up like this person, who's, of course, Joan of Arc. And she didn't do well. So, first of all, what is conventional wisdom? It's generally accepted belief, opinion, judgment, prediction, whatever, about any particular matter. But conventional wisdom is not sacred. If it appears to you that what is always taught may be incorrect, there may be a better approach, never be afraid to ask why. Don't ever accept the answer, it's what's always been done. And if you don't get a satisfactory explanation based on proven facts, it's your right and your duty to challenge conventional wisdom, since it may be conventional practice, but not really wisdom. So what do? You design a study and determine whether the generally held belief is true. And if the results prove that conventional wisdom is not true, don't be afraid to rock the boat and share your conclusions with others in the radiology community. So I'm going to give you some examples that actually occurred in our institution. And as Tom said, I do not do CT, MRI, or ultrasound, so I have to find something to cause trouble so that I can actually write some things. So for patients who have a positive PPD, the CDC recommends that you have a screening chest radiograph to confirm or exclude a diagnosis of pulmonary TB. And this, the CDC says, is a PA radiograph and additional radiographs performed at the physician's discretion. So what's the problem? The problem is it's impractical to evaluate the need for a lateral view in each patient. There's a high number of patients referred for chest radiographs, and you need efficient throughput. So the general solution at the time was that all radiology departments in Boston, as well as ours, perform PA and lateral routinely to screen for TB in patients with positive PPD. But the question is why? And anecdotally, we'd had interpreted large numbers, let's say, of pre-employment chests, asymptomatic individuals. We didn't remember finding anybody with an acute case of TB. So you design a study. And we did 875 adults who had positive PPDs and employee health ordered a chest x-ray. We had 2 people experienced looking at them, and we wanted to find out, did the radiographs show any evidence of acute TB or findings suggesting old TB, like are listed here? So we did a PA alone, then we did a PA and lateral, and to see, was any findings seen only on lateral? And if it was on both views, did the lateral view help anything about what the PA did? The PA view alone showed old TB exposure in almost 10% of patients and no active TB. The lateral view showed no abnormality in 82% of subjects who had abnormalities on the PA view. All abnormalities seen on the lateral view were seen on the PA, and when you were seeing it on both of them, the lateral view never helped. The radiation dose, which surprised me, is that the chest lateral view is 2/3 of the dose. So if you eliminate the routine lateral view, you reduce overall patient dose by 2/3, no loss of diagnostic accuracy. I just love pictures. These are all from Biopark in Valencia. If you ever get a chance, go to it. Okay, so going to TB again, most cases of acute TB arise from reactivation of dormant foci of infection. And that's the whole principle, basically, in the United States to eliminate active TB. So the conventional wisdom is that screening chest radiographs are critical to obtain, though in those with positive PPD, not only to exclude active TB, but to detect evidence of old healed disease to be able to assess reactivation risk. But again, anecdotally, we remembered seeing huge numbers of asymptomatic individuals with positive PPD. Again, none of us could remember seeing a case of active TB. So what we decided to do was do 2,500 people to see whether all this stuff really was in any value. Most of these people in our place were really high risk for TB. They weren't born in the country, they had multiple risk factors, and they had large indurations. And we found a 6% positivity rate of old TB, and we found 2 non-calcified nodules, less than 4 millimeters, which at that time were the FLEISCHNER criteria. One was a lung malignancy, and one was a necrotizing granuloma, but not AFB. You have to show some chest radiographs, and this is a image you can see, which was much clearer seen on CT, which was a carcinoma. Here's one without the arrow. I'm not sure you would have ever seen it. And this was Mycoplasma kansanaceae. So again, why do we get all of these 2,500 studies? To exclude TB, and if I hit it right, to assess for evidence of prior TB, which would have a higher reactivation risk and could warrant being given some therapy. So, of more than 2,500 patients, we found no active TB. Now, we assessed for latent TB, there were 6.1% of abnormal examinations, and you see the ones there. They're the standard things you'd say consistent with old TB exposure. So the question is, have any of these been proven to be associated with latent TB and a greater chance of reactivation TB? And the answer is no. There's never been a study that has shown that any of these have any significance whatsoever. And indeed, there's no interest in it, because I approached the people at Kaiser Permanente who have this large, especially in the West Coast, confined population. I thought we could do something like a 10-year study. They really weren't interested in it at all, because nobody wants to know. There's a very powerful TB lobby, and if anyone wants to talk to me afterwards, I can regale you with stories about that. So the conclusion is the chest radiographs screening for positive PPD in a pre-employment setting, extremely low yield in detecting either active TB or increased latent TB, and it provides no assistance to decide which individuals to prioritize for treatment of latent TB. Why do we do it? Well, the hospital sometimes says that we have to, but does it make any sense? We then did a study of similar number of people, just general inpatients and outpatients, who come in with a clinical history of positive PPD. The vast majority were absolutely normal, and most of the others showed some findings consistent with old tuberculous disease, which may or may not be true and has no significance. We had 3 cases of active TB. One person, severe cough and fever, would have gotten a chest x-ray anyway. Interestingly, he was sent over from the Mass General. He worked at the Mass General. One person from Haiti, high endemic place, that needed a chest x-ray for nursing school, I guess is reasonable. And one person had amenorrhea, which I found out is associated with active TB. We had 200 cases in which their symptoms were fever, cough, the whole bit, and we found 11 cases of acute pneumonia in those patients. So that's reasonable to do. But there were 2,300 general inpatients and outpatients, no relevant clinical symptoms, 2 cases of active TB, less than 0.1%. So is routine screening of these individuals really worth it? Something you have to think about It depends on your philosophy. So, conventional wisdom is that chest radiographs should always routinely be obtained after chest tube removal in patients with cardiac surgery to look for pneumothorax. That sounds pretty reasonable. The problem is, in our experience, we didn't remember hardly seeing any cases of pneumothorax at all after cardiac surgery. Is it possible to get a subgroup of these patients for whom routine chest radiographs aren't needed? So we did a study of 400 consecutive cases. We looked at the chest films, and we asked the referring clinicians to estimate the likelihood of a pneumothorax. Not taking, in those who had the least possibility of pneumothorax, we could have eliminated more than 85% with only missing 6 pneumothoraces, none of which required medical or surgical intervention or a delay in discharge. So, chest radiography performed after chest tube removal basically is necessary in 13.7% of patients who have respiratory, rather only in those who have respiratory or hemodynamic changes, or if there are any chest tube problems, we know technically. But when you do some of these things, you get some frustration. Despite this evidence, the cardiac surgeons at our institution still order routine chest radiographs after chest tube removal. And what's really galling is that the co-author on the study was and still is the chief of cardiac surgery. So you may show that something is ridiculous, but people will still end up doing it. But at least you've done your job. Now, conventional wisdom would be that radiologists, if there are professional guidelines firmly based on extensive scientific evidence, that radiologists would, of course, follow them. Sounds reasonable? This is the old FLEISCHNER guidelines. You know, there are new ones, but this is, I don't have a picture of the new ones. So we did a study. Are radiologists aware of these criteria, and do they actually use them in follow-up recommendations? 7,000 questionnaires, only got 834 back. We asked for their current management strategies for incidental non-calcified nodules in 3 clinical settings. 80% were aware of the FLEISCHNER guidelines, which was amazing, and 50% adopted them. And these were the guidelines, the scenarios rather. This was one who was too young, one who was old enough but didn't smoke, and one who was old enough and did smoke. Those who are aware in black and those who are unaware in white showed dramatic differences in conforming with the guidelines. But notice something about the middle two. Even those who knew the guidelines, 50% more than 50% got the answer wrong. So 80% were aware of the guidelines and had the highest rate of compliance, but these were still below 50% in 2 categories. So conventional wisdom, again, turned out to be wrong. Now, I think everybody would agree that we want to do the best for our patients, and we want to make sure that we're taking good care of them, and that techniques like, for peer review, like the RAD-Peer that many of you have, are valuable tools for improving radiology performance. So we did a study. We wanted to find out the nature and frequency of the type of clinically relevant errors that are identified by peer review, such as RAD-Peer. These are randomly selected cases. And we wanted to get an idea of how much time do you actually spend doing this, so you're getting any bang for the buck. This is the classic RAD-Peer system. Right now, 3 and 4 are put together, but it's the same principle. In 6 years of chest radiology, we had almost 10,000 cases. And when we did this routine peer review, 97.5% were categories 1 and 2. Only 24 cases, that's 2.5%, had a category 3 or 4 error. But then the question is, how many of these could be clinically valuable? And these were only 114, or 1.2%, could have possible clinical importance. It took 39 cases to find one category or 3 or 4 error. 83 cases to find one that was relevant. And what happened is that we showed that it took about a minute to go through every of these cases. So it took about an hour and 23 minutes of radiology time to find one clinically relevant abnormality. Over the 6-year period, the total time expended was at least 20 days of full-time effort. It's quite a lot. This is the time to detect each error. It's a terrible slide. I apologize. But what it says is, for example, if you wanted to see a mass or a nodule that was missed, it would take 26 hours and 14 minutes to find it. And for, let's say, a rib lesion, 39 hours and 20 minutes of looking at these things to find one relevant missed lesion. So our conclusion is that the RAD-PURE-like system of reviewing a specific number of randomly selected cases detected only 1.2% of clinically relevant error and a ridiculously high amount of time in work hours per radiologist. So does peer review improve radiology performance? And I don't know if you guys are aware of the literature, but the answer is no one knows. There has never been a study that shows performance improvement related to peer review. The American College of Radiology, boy, this is against conventional wisdom, makes a fortune every year by being the collating agency for it. But no one knows if it works, and quite frankly, no one's interested in finding out. Could there be a better way, perhaps? So we have an online QA system where radiologists, in their usual types of duties, checking old films, preparing for conferences, or clinicians who see something that we did wrong because it turned out that that wasn't clinically correct, they could electronically enter errors, and so that these all were done during regular activities. Now, the peer review, there were 114 cases using that system, and you'll notice, looking at these, that about 50% are related to the presence and degree of pulmonary vascular congestion, pleural effusion, or enlargement of the cardiac silhouette. So the question is, number one, from your experience, it's really difficult sometimes to know, is there a little bit of congestion? Is it normal? Is the heart a little bit big? Is it upper limits of normal? And the key thing is, who really cares? So at least 50% of these things, no one cares about. The QA system, which people are doing as part of their normal work, first of all, had more than 3 times as many cases, and more than 50% talked about things which I think are important, like missing an abdominal lesion, or a skeletal abnormality, or a mass. And only 3.6% related to the pulmonary vascular congestion type thing. So our conclusion is that the QA system identifies cases that have a much higher level of clinical relevance. They're detected during normal, regular activities or reported by referring clinicians. So why do we do RAD-PEER and things like that? Well, what's the future? Peer review of random cases will mercifully disappear completely within a few years, and it'll be transformed into peer learning based on a concept pretty much identical to our online QA system. And the only reason this is going to happen is that we and a lot of other places have shown that these are basically worthless activities. And what's even worse is, in a different paper we showed, we interviewed all of our staff people, and about a quarter of them were convinced that results on peer review were used to get rid of people or lower their salaries because they didn't do well, both of which is totally wrong, but that was their conventional wisdom. Okay, I think I'm doing well. This is the last general thing, and it's, well, that radiologists would only be listed as authors on scientific articles if they make a substantial contribution to designing a study, performing it, and writing or approving the manuscript. Radiologists are intellectually honest. They're going to only take credit for research if they deserve it. There is something called honorary authorship, means that somebody who didn't really meet the criteria for authorship gets onto a paper. So it increases their bibliography, but it decreases, or at least relatively decreases, those who actually worked. These are the ICME guidelines for authorship. You can read them faster than I can. And so what we did is we sent questionnaires to first authors of radiology and European radiology to identify how many of them thought that anyone in their group took credit when they shouldn't, and were there any specific factors that caused this. These are criteria that are considered non-authorship tasks, and meaning that you shouldn't take credit. Things like just signing a copyright transfer form, finding cases, contributing a couple of illustrations. These are not supposed to be worthy of authorship. We found that 26% of authors perceived that one or more co-authors did not make sufficient contributions. And what's scarier, 59% reported that one or more authors performed only non-authorship tasks, according to these criteria. Section head, being the automatic, or department head, automatically listed as an author, was a critical thing, and in 25% of institutions represented, this actually occurs. As you might expect, those with lower academic rank and less experience, fewer journal articles, had much higher perception, probably because they weren't able to say no. There was an editorial in Radiology asking, was there any geographical distribution of this? So we did a study on that, and we shown that the total amount of perception and authors doing non-authorship tasks was virtually identical. But the perception of honorary authorship was much higher in Europe and in Asia than in North America. As you can see, almost twice as much in those countries. There, as I said, there was an editorial, really a flaming editorial that was written, something about, is there any honor in honorary authorship? And it was both in the Radiology and European, it was a combined editorial. And there was an International Society for Strategic Studies which had a whole meeting, and they decried the whole idea of honorary authorship, said that they're going to make sure it's not going to occur in their institutions. So, conventional wisdom would be academic radiologies comply with the policies of major journals and the decisions of international organizations of leading radiologists. And everybody would agree with that. So what did we do? We just did a study to try to find out, is that true or not? And perhaps to no one's surprise, there was no improvement. Perception of honorary authorship actually went up, but there were more young people, and non-authorship tasks also went up. So the conclusions, neither radiology journals nor statements by international organizations had any positive effect, and major contributing factors, because we had a comment section, are financial rewards for honorary authorship and academic advancement based primarily on the number of authorships, not quality. If you want to learn more about that, and you're here tomorrow morning, we have a refresher course at 8:30, and they're going to be the former editors of both the European radiologists, one from Britain and one from France, who are also going to be talking about why the problem is and what they might be able to do to improve it. And the takeaway points, as I saw you, don't be afraid to challenge conventional wisdom. If it doesn't appear to conform to your experience or seems to make no sense, perform a study to determine whether conventional wisdom really is wisdom. And the key, publish your results, do your part in shaking up the radiology community. because only you, if you find something wrong, can actually make a change. And thank you very much for inviting me.